All right, so let's talk about the other abnormalities that can we search for on an EKG. And it's by far the most common abnormalities that you can find on an EKG, the most important bits, and that is arrhythmias. So to revise from previous videos and developing our 9-step search pattern, let's stop at 8, but eventually we'll come to that. So in our 9-step search pattern, the first thing we do is we assess for the heart rate. Then second, you assess for the intervals of the sinus rhythm. The intervals being the PR interval, as well as the QT interval, as well as the QRS complex. Are they normal or are they not? And then you check for the axis. You check the axis of the P wave, the QRS, and the T wave, with the most important bit being the QRS, whether there is left or right axis deviation or extreme right axis deviation. And then following that, we come to, obviously in previous videos, we went to step number 7, immediately where we assess for ventricular hypertrophy as well as atrial enlargement. We went to step number 7 immediately because it's a lot more easier to explain, and it was implementing some of the stuff that we were learning together up to that point. But now, this time, we're going to go in order. Now, I've concluded, or I've mentioned, the first 3 steps: the heart rate, the intervals, and also the axis. So now we're going to go in order. Now we're going to go to step number 4 that you can assess. And that's checking whether the rhythm that you see, the PQRST, is it a normal sinus rhythm or is there a rhythm disturbance? If there's a rhythm disturbance, you have what is known as arrhythmia. And it's at this point you ask yourself, is this a sinus arrhythmia or a non-sinus arrhythmia? Mumtaz. So one of the ways, there are many ways that could disrupt the rhythm. There are many ways in which there can be there's many ways in which there could be a rhythm disturbance, all right? So before we talk about how the rhythm could be disturbed, let's just revise one more time, all right? Let's just revise one more time the conduction system of the heart. So here we have a picture of the heart, right? You have the right and the left atrium, the right and the left ventricle. And here we have in the red color the conduction system. You have the SA node, which is your pacemaker cell, the main one, which transmits to 60 to 100 action potentials per minute. This one is sending action potential or a wave of depolarization, depolarizing the right atrium, followed by the left atrium by Shara Malik Abdullah, the shortcut pathway, giving us the P wave. And then it will send it to the AV node, where the AV node will not send this action potential downwards just yet. The AV node, which is placed near the, near the junction between the atrium and the ventricle, it will cause a conduction delay of up to 0.1 millisecond. Mumtaz. So it will wait. So we will have this flat line, giving us the PR interval. And then eventually after 0.1 millisecond, after the ventricles have been filled with blood, when they're relaxed, now it will send the wave of depolarization downwards towards the bundle of His. Mumtaz. And towards the bundle of His, there will be a septal depolarization, giving us the Q wave. And then it will reach towards the right and the left bundle branch, which is branches from the bundle of His. So we have the right bundle branch and the left bundle branch, where it will depolarize the right and the left ventricle. Of course, the left ventricle will be more bigger in size than the right, so it will be more depolarized. So the R wave better represents left ventricular depolarization. So that's what's going to give us an R wave, an upward deflection. And then eventually, the wave of depolarization will reach the Purkinje fibers, going towards the left and right, going a little bit away from the positive electrode of whatever led, and it will give us a negative deflection known as the S wave, and then eventually it will reach the baseline. And then following this wave of depolarization that was going inferolateral towards the left, following that, there will be a refractory period. You see, there will be a flat line here, and then follow this flat line, there will be the appearance of a T wave, which represents ventricular repolarization. The reason why there's a flat line following ventricular depolarization is because following depolarization, there will be some time, there will be known as a refractory period, in which the ventricles, they will depolarize, and then at some point, they will take some time to relax. There will be some time to wait for repolarization to occur. So we will go back to the baseline, And eventually, we will wait a little bit of time for repolarization to occur. So there will be, back to the baseline, eventually repolarization will occur. Well, it will occur the opposite way. So a wave of repolarization will be away from the positive electrode, giving us a positive deflection known as a T wave. And then following repolarization, we will wait. There will be, again, a refractory period where there will be no depolarization until all the chambers of the heart are fully repolarized. Then, once they are fully repolarized, we come to the next sinus beat, which is PQRST sinus rhythm. ممتاز? So this is just a quick revision of the conduction system of the heart and giving us this EKG tracing that can be found in Let 2, for example. ممتاز? Alright, now this is the normal, and this rhythm can be disturbed. This pathway can be disturbed, and it can give us an arrhythmia. ممتاز? And there are many ways in which an arrhythmia can occur. For example, before we talk about that further, one more thing I just want to mention. All right, just one more thing I want to mention regarding the conduction system of the heart. I told you before that the pacemaker cell people refer to are the SA node, but we have other pacemaker cells. You know, it's not just the SA node. We have other cells that could also function as a pacemaker. They could also give their own action potential at their own rate. For example, in the green color, we have a pacemaker cell that is found in the atrium, but it's not the SA node. We have atrial pacemaker cells. And these ones can send an action potential between, let's say, for example, 60 to 75 action potentials per beat. And then you have the AV node itself. The AV node can also function as a pacemaker cell, you know? It can also send an action potential between 40 to 60 beats per minute. And then you have a pacemaker cell that might be found in the ventricles. They are known as ventricular pacemaker cells, and they can generate between 30 to 45 action potentials per minute. So you have other pacemaker cells in the atrium, in the AV node, and in the ventricles. However, the big one, the main one, will always be the SA node, between 60 to 100. This is the one that's usually the fastest in conducting its action potential, so it will always overwhelm all of its competitors normally. So that's why our normal sinus rhythm will come from the name sinus, as in all our action potential will originate from the SA node. A P wave, followed by a QRS wave, followed by a T wave. ممتاز? And these pacemaker cells, they will not be able to force themselves in sending their own action potential overwhelming the SA node, unless there's an abnormal case. ممتاز? Now that we talked about these pacemaker cells, that we talked about also in previous videos, but we're just going to revise them. And if you remember as well, we talked about the other types of cells in the heart, like the myocardial cells and the conducting cells. And we talked about now the pacemaker cells in a little bit more detail, again as revision. Now we can talk about, now that we've talked about the normal sinus rhythm, by the way, PQRST, and how that occurs, now we can talk about how this rhythm can be disturbed. Now, the rhythm being disturbed, known as arrhythmia, it can be known as two things. It can be known as either sinus arrhythmia or non-sinus arrhythmia, or asinus arrhythmia. ممتاز? So either the arrhythmia, it comes from the SA node, or it comes from a place besides the SA node, an ectopic source, an ectopic foci, like an ectopic foci in the atrium besides the SA node, or an ectopic foci in the ventricle, or within the AV node, whatever. ممتاز? So it can come from either arrhythmia, either from the SA node or from a place besides the SA node. ممتاز? And one of the ways that can occur, one of the ways that can be a rhythm that's being disturbed here, that can occur, is that we could have a sinus arrhythmia, meaning the conduction goes through this normal pathway, so the normal conduction system. There is a normal sinus rhythm. However, the problem is that the electricity, the action potential that's going through this normal pathway, it may be too fast, or it may be too slow. So, if we have the speed in the sinus rhythm, if we have an action potential that's going very fast throughout the normal pathway, they call this sinus tachycardia. in which the heart rate is above 100. And if the action potential is going too slow throughout the normal pathway, the action potential is still coming from the SA node, but it's going a bit too slowly through its normal pathway. This is known as bradycardia, in which the heart rate is below 60. You still have a PQRST. You have a sinus rhythm, but it's too slow in brady or too fast in tachycardia. So they named this sinus arrhythmia. Mumtaz, arrhythmia arising from the SA node. Now, this is sinus arrhythmia. Now we come to the other part, which is non-sinus arrhythmia. You have an arrhythmia arising from a place that's not coming from the SA node. Anywhere besides the SA node. Mumtaz. So we have what we call non-sinus arrhythmia. Mumtaz. And regarding non-sinus arrhythmia, we want to ask ourselves a question. If we have an arrhythmia that's not coming from the SA node, Mumtaz, it's not a sinus in origin. If it's not coming from the SA node, we have a non-sinus arrhythmia, we need to ask ourselves, is there an ectopic source? Is there an ectopic foci? And if there's an ectopic foci, is it coming above the ventricles, supraventricular source, or is it coming within the ventricles, a ventricular source? Mumtaz? So, if it's coming above the ventricle, then we might have a case of supraventricular tachyarrhythmia. And if it's coming within the ventricles, we might have a source of ventricular tachyarrhythmias. In supraventricular tachyarrhythmias, you are likely to see a P wave. In ventricular tachyarrhythmia, you will never see a P wave. The second thing, in supraventricular tachyarrhythmia, where the source is above the ventricles, you might see a narrow QRS complex, suggesting the ventricles are fine in depolarization. But if we have a ventricular tachyarrhythmia, meaning the source, the ectopic source, is within the ventricles, you might not see a P wave, and you might see a wide QRS complex, suggesting an abnormality in ventricular depolarization. So that's the question we need to ask ourselves. Whenever we have a non-sinus arrhythmia, we need to know, is it above the ventricles, supraventricular arrhythmia, within the right atrium chambers, an ectopic source besides the SA node, or is it below the supraventriculars? Yani it's within the ventricles themselves. Is this a case of ventricular tachyarrhythmia, in which you have an ectopic source within the ventricles? Mumtaz? And there's a lot of differential diagnosis, a lot of conditions that belong to supraventricular tachyarrhythmia, or they call it narrow complex tachycardia. And we have a lot of differential diagnosis belonging to ventricular tachyarrhythmia, or wide complex tachycardia. Mumtaz? Mumtaz. Alright? Alright. Now, let's go further into how this rhythm could be disturbed, and we can classify it as non-sinus arrhythmia. Mumtaz? So we finished with sinus arrhythmia, alright? Where everything is normal, but it's a little bit too fast or a little bit too low. Mumtaz? Now, non-sinus arrhythmia. Here we can have a disturbance in the rhythm. If, for example, we have an action potential that is arising from a source that's not coming from the SA node, for example, we have an ectopic source or an ectopic foci, such as from an atrial pacemaker cell, that's sending its action potential towards the AV node and towards the left atrium, basically replacing the job of the SA node, then this is what is known as an ectopic rhythm. Mumtaz? An ectopic rhythm, from the name, you have an abnormal rhythm. An abnormal rhythm arising from an ectopic source. This can come from an ectopic foci seen in the right atrium or whichever atrial chamber. This can also arise from the ventricular chamber. Mumtaz? So we have an ectopic source from anywhere but the SA node. Anywhere but the SA node. It can even come from the AV node itself, and we will see. So that's ectopic rhythm. Another way the rhythm could be disturbed is that we have a reentrant rhythm. A reentrant rhythm basically means is that we basically have a loop. We have a loop circuit, and this loop circuit will continuously produce action potential all over the place. And we'll talk about that shortly. Another way the rhythm could be disturbed is if there's a block in conduction. Imagine the conduction system is the same, alright? It's normal. The SA node is sending its whole thing, right? But we have a block. We either have a block on the SA node, which means there's sinus block, which means the person may present with sinus arrest, or asystole, because there's no action potential coming from the SA node, so there's no action potential going towards the normal pathway. So there's one way conduction can be blocked if you block the SA node, or you could have a block on the AV node. And if there's a block on the AV node, here you assess the severity. Is it first degree, second degree, or third degree accordingly? That will be in upcoming videos. Or if you don't have a block on the AV node, you could have a block on the bundle of His, or you could have a block on the right or left bundle branches. Alright? And this will give us right and left bundle branch block. We'll see it in upcoming videos. Mumtaz. So you could have a block in the conduction system. Everything is normal, but there's a block in the way. Mumtaz. Mumtaz. We'll talk about that in detail in upcoming videos. And finally, another way that the normal sinus rhythm could be disturbed, besides an ectopic source replacing the SA node, besides a re-entrant loop circuit replacing the SA node, besides a block in the conduction system, another way the rhythm could be disturbed is if there is an accessory pathway, like in Wolff-Parkinson-White syndrome, in which you have here what is known as an accessory pathway. So if you have an accessory pathway, let's draw it in the green color. For example, we'll talk about it in detail in future videos, but if you have an accessory pathway, which is between the right atrium and the left ventricle, Mumtaz, and this accessory pathway, such as in Wolff-Parkinson-White syndrome, otherwise known as the bundle of Kent, if you have this accessory conducting pathway, this allows the action potential arising from the SA node to basically evade the AV node. It can go immediately towards this conducting pathway and find it immediately downwards towards the ventricles. And why is this a problem? Well, this is a problem because if you remember, the AV node, its purpose is that once it receives action potential, it will not send it downwards for 0.1 millisecond. Conduction delay. But here, this accessory pathway next to it, it can bypass the AV node. And if it bypasses the AV node, there's no delay. So it will lead to us arrhythmia. It will lead to a lot of problems, and especially very lethal arrhythmias that will be seen arising from the Wolff-Parkinson-White syndrome. We'll talk about that in future videos. So that's one way the rhythm can be disturbed. If you have an accessory pathway, a shortcut, Mumtaz, or a block in the conduction, or a re-entrant rhythm, a loop circuit, we'll come to that, or an ectopic source, sending its own action potential, Mumtaz. Or, besides non-sinus arrhythmia, it could be completely normal. You could just have a normal sinus rhythm, but the amount of action potential that's being sent is being affected. It can be too fast, tachy, too slow, bradycardia, Mumtaz. All of that together represents arrhythmia. Non-sinus and sinus arrhythmia, rhythm disturbance. Mumtaz? Mumtaz. And we talked about also the difference when we're assessing non-sinus arrhythmia. We want to know the source. Is it above the ventricles or below the ventricles? Supraventricular? No, there's supraventricular. There's a P wave with a narrow QRS complex. In ventricular tachyarrhythmia, there's no P wave and there's a wide QRS. And we will summarize that by the end of the video. Mumtaz? Mumtaz. Now, when we come to now step number 4 of our search pattern after the heart rate, interval, and axis. And regarding our step number 4, when we are assessing the sinus rhythm, we ask ourselves 4 questions or 5 questions. Actually, there's 5, but you already answered one of them at the first step, which is the heart rate. But we'll assume 5. Mumtaz? So you can ask yourselves 5 questions. Number 1 is the heart rate. What is the heart rate? And we talked about the heart rate in previous videos, where if you want to assess the ventricular heart rate, RR interval, or you want to assess the atrial heart rate, PP interval. We talked about in previous video. So you want to ask, what is the heart rate? And then you ask yourselves about the P wave. Is there a P wave that's present here or not? And if there is a P wave, you want to see how many P waves are present, Is it one P wave or a bunch of P waves per beat or not? So you want to ask yourself, is there a P wave present or not? And if it is present, how many are there? Mumtaz? Mumtaz. So that's the first question you ask yourself. The second question, or the third question, the QRS. Is the QRS wide or narrow? You should know that the QRS should be narrow, meaning that when there's ventricular depolarization, it's very fast, it's very efficient, and it's very fast. So in EKG, it will appear narrow. It will not appear widened. If it's widened, that means it's not going through the normal pathway. It's coming from an ectopic source, like the ventricular pacemaker cell. So you can have a narrow QRS, that is the normal part. So you need to ask yourself, is it wide or narrow? And if you remember from previous video, you know the duration of the QRS, you count the number of small squares, it shouldn't be no more than 2 small squares, 0.08 seconds. Mumtaz? Mumtaz. Then the next question you ask yourselves, what is the relationship between the P wave and the QRS? Basically, do you have a QRS that is preceded by a P wave? Meaning, is there a P wave followed by a QRS, or a QRS that is preceded by a P wave? Is there a relationship between the two? And that is the normal. That means that you have a sinus rhythm. That means the action potentials arising from the SA node, giving you an upward deflection P wave, with followed by immediately a QRS. Mumtaz? So you check for that as well. And then you ask yourself, is the rhythm regular or irregular? Mumtaz? And we talked about that in previous videos. You measure the distance. Between this R wave and this R wave, the R interval, if they're equal distance or not. You have a regular distance or an irregular distance. Mumtaz? Mumtaz. So those are the questions you can ask yourself in assessing the sinus rhythm. Now let's go ahead and start the video off, this video, by talking about what is the normal sinus rhythm, and now what are the non-sinus rhythms, the non-sinus arrhythmias that we may see, starting with the supraventricular tachyarrhythmia or narrow QRS complex tachycardias. Mumtaz? Mumtaz. Okay. So the normal sinus rhythm is, as you can see, a PQRST in which the heart rate is between 60 to 100, and the P wave is present, upward deflection lit 2, and the QRS is narrow, and the relationship between the P wave and the QRS is there, and you can see the rhythm, it should be regular, equal distance each time. Mumtaz? In the RR interval. So this is what is known as your normal sinus rhythm. Mumtaz? And if anybody asks, what about the interval? What about the segments? Again, this is part of your search pattern from before. You assess the heart rate, you assess the interval, you assess the axis, and then step number 4, you assess the remaining questions for the sinus rhythm. So regardless, as a summary, this is a normal case of a normal sinus rhythm. Mumtaz? Now, let's talk about supraventricular tachyarrhythmias. Let's talk about a rhythm disturbance belonging to non-sinus arrhythmia, where specifically we will see a problem in ectopic rhythm and in reentrant rhythm, specifically these two, where they can give rise to us above the ventricle supraventricular tachyarrhythmias, where most of them, not all of them, but the majority of them will have a narrow QRS, and they either will have a P wave or a hidden P wave. We will see according to the arrhythmia. Mumtaz? Now, before we talk about each one, I just want to mention one more thing. Mumtaz? Now, we already talked about sinus arrhythmia, how it can be tachycardia, everything is normal, it's just that one is too fast, one is too low, and one is too slow. Now we just want to talk about one more concept that you need to know. A lot of these arrhythmias, a lot of them may occur due to a whole lot of factors. A lot of them may occur because a person may have a heart disease. A lot of them may occur when a person has a completely healthy heart. However, he might have drank alcohol, he might have smoked, he might have done drugs, he might have drank caffeine. All of these are arrhythmogenic factors. These are factors that can predispose to arrhythmias. Someone might have used certain drugs. Some person might have had an electrolyte disturbance, hyperkalemia, or a sympathetic stimulation. Regardless, there's a lot of arrhythmogenic factors that can predispose to arrhythmia. And the thing about them is that they can predispose to what is known as a premature beat. What is meant by premature beat? Meaning an action potential may be sent too early. Meaning as soon as one sinus beat is finished, another beat, another action potential is sent immediately and causing premature contraction of the chambers. And that can predispose to a lot of arrhythmias. So let me give you an example right now. For example, this is normal, right? You can see how following one normal sinus beat, there's a delay, there's a refractory period where all the chambers, they must be fully repolarized. There's a refractory period in which while they're repolarized, they will not accept any depolarization. Any depolarization coming its way tells it no. get out of the way. I am the chamber. I'm being repolarized. This is a wave of depolarization coming towards me. I tell it, no. I'm not finished. I'm taking a break. Go towards the other side. Mumtaz? So that is what's going on right now. So that's why we have a flat segment, and then after that, shortly, we will have another sinus beat. Alright? Now, in some cases, when a person drinks caffeine, certain drugs, sympathetic stimulation, hypoxia, whatever condition may cause arrhythmia, Mumtaz, you see what could happen here? What could happen here is that we could have an early beat, an action potential that's being sent way too early while these chambers are being repolarized. So, what you could have here is that as soon as the T wave is finished, you may see this shape. It may look like this. Now what's going on here? Well, we can see as soon as this beat is finished, literally before it's even finished repolarization, we will see another beat. And this beat, it will have what? It will have a P wave. This P wave joined with the T wave. And now we have a premature beat. This premature beat, in which you will have a P wave, this joining with the T wave, but there's still a narrow QRS complex. This is known as a premature beat that's originating in the atrium. They call this premature atrial contraction, PAC, Mumtaz, in which you have a very early beat originating from a source besides the atrium and a source besides the SA node. It can come from an ectopic source here, releasing way too early of an action potential. As soon as this one is finished, thus the P wave of this one will join with it together and will give you a very early beat. From the name, premature atrial contraction. And in some cases, it may be very early, In some cases, it might give you a different image or a different characteristic. Instead of this image, it might give you this appearance, where as soon as the T wave, you might see a P wave right here, and nothing till the next one. Why? Why do I just only see a P wave following this sinus beat? This P wave right here, where there is no QRS complex, suggests you have a premature atrial contraction, but it's blocked. It's blocked. That means the action potential, it depolarized way too early the atrial chambers. However, when it came to the right and the left ventricle, it told it, no, I am still repolarized. So I have a refractory period. I tell you to go somewhere else, go through the atrium. So that's why on an EKG, you might only see a P wave, followed by nothing, and then after that, you might see a normal PQRST. Mumtaz? So that is known as a blocked premature atrial contraction. But in most scenarios, you might just see a P wave. Or in some scenarios, you might see an inverted P wave. Mumtaz? Followed by the same stuff. You might see a narrow QRS complex, you might see a T wave, but you might see in its place a retrograde P wave. A retrograde P wave in lead 2 basically means we have an ectopic source, okay? An ectopic source that's sending its action potential the opposite way. It's going the opposite way. So basically, let's say for example the AV node. Let's say the AV node, it's acting on its own. It's sending its own action potential. And this one is sending its action potential the opposite way. So now it's going to depolarize the atrium the opposite way. Then in that case, lead 2 will see the wave of depolarization moving away from it, and this will give us a retrograde or an inverted P wave. And that is another sign of premature atrial contraction. So premature atrial contraction means you have a very early action potential that's being sent and causing depolarization of the chambers before they're able to fully repolarize, or as soon as they're fully repolarized. So it might appear as a retrograde P wave, followed by everything normal. It might appear as a P wave joining with the T wave of a previous beat, or you might only see one P wave followed by no QRS complex, suggesting that it's been blocked. It's super early. Mumtaz? And this is important because premature atrial contraction is something that can predispose to arrhythmias. It can predispose to such an arrhythmias, and we will see eventually later on. So that's premature atrial contraction. And by the way, the same concept also applies when you also have a premature contraction of the ventricle, known as PVC. We'll come to it in the next upcoming video. The same concept, but this time we have a very early action potential depolarizing the ventricles, coming from a pacemaker cell in the ventricles. We'll see that in the next upcoming video. Now, we talked about this concept, and that's very important, and that is the premature atrial contraction. Another important concept to keep in mind is the opposite. For example, besides PAC, for example, let's say this person, for example, has a block in the SA node. The SA node is not sending its action potential. Well, if the SA node is no longer able to do its job, that means these pacemaker cells, they can be free for all. They will be able to do their own stuff. They will be able to send their own action potential, especially the pacemaker cells of the ventricles. Basically, if the ventricles is not being depolarized from whatever source from above, from the AV node, from the SA node, or from whatever nodes above the ventricles, if the ventricles are not being depolarized, then these pacemaker cells of the ventricles between 30 to 45 beats per minute, they will act on their own. So especially if a person has a block in the SA node, or a person has, for example, some sort of cardiac arrest, or whatever, or a third degree AV block, whatever, block in the AV node, SA node, doesn't matter. Regardless of the ventricles not being depolarized from the source above, these pacemaker cells will act as life support. Basically, they will send their own action potential to depolarize the ventricles. But you see, on an EKG, there are two abnormal findings. There's two findings that will confirm that this beat, this rhythm that we will see, it arises from the ventricles and not from anywhere else. For example, you might see a sinus arrest, okay? You might see a sinus arrest. And then after some point, you might find this finding right here. You will see this finding. What is this finding right here? Well, what we see here is what is known as an escape beat. This is known as an escape beat, or in some books, idioventricular rhythm, accelerated idioventricular rhythm, or escape beat. What does that mean? It means when a person has no action potential, when the ventricle has no action potential coming from the SA node or the AV node, the ventricle has no electricity, the pacemaker cells of the ventricles, which operates between 30 to 45 beats per minute, they will be the main guys that will depolarize the ventricles. The thing is, when they depolarize the ventricles, they will be towards this direction, you know? They will be all over the place. They will not go inferiorlaterally. And if they go inferiorlaterally, even then, they will be all over the place. And they will cause depolarization of the ventricles, but the depolarization is not as efficient. It's not as narrow on an EKG. It's not efficient because it's too slow, and its depolarizing of the ventricles takes time, unlike in comparison to the SA node. So what does that mean on an EKG reading? That means the QRS complex, but what you're seeing here is the QRS complex. This QRS complex will be wide. It will be wide and bizarre looking because what is actually depolarizing the ventricles is the pacemaker cells of the ventricles. And these pacemaker cells, they're depolarizing, but they're way too slow. They're way too inefficient. They take a lot of time to depolarize the ventricles at 30 to 45 beats per minute. So you will see a QRS complex that is wide and bizarre. The duration is increased. Mumtaz? Along with that, if you notice, there is no P wave. You will not see any P wave because this source, this electricity, doesn't come from anywhere from the atrium. It comes exclusively in the ventricles. So, in an escape beat, following a sinus arrest or no electrical activity, you might see a wide QRS complex with no P wave. And this occurs late. This occurs after some time. This is what is known as escape beat. And if you see the same finding, however, if you see a wide QRS complex but no P wave, and this one occurs immediately after this P wave, immediately after it, the opposite, then this is known as PVC, premature ventricular contraction. So, premature ventricular contraction as well as escape beat, both of these are the same thing. They both will have a wide QRS complex without any P wave. Both of them will come from an ectopic source which is the ventricular pacemaker cells, ممتاز, which operate between 30 to 45 beats per minute. The only difference between the two, this one will occur following a sinus arrest. This one will occur late, following a sinus arrest. This will act as a life support. While in PVC, this one will occur early, premature, early, as soon as possible. And this one could be dangerous if we look for specific signs, which we will see in the upcoming videos, ممتاز? Because this can predispose to ventricular tachycardia. So we have PVC, escape beat, the same finding, but this one occurs early, as soon as possible, following this T wave of a previous beat. With escape beat, on the other hand, an escape beat can occur late. The difference between the two is timing. So we talked about PVC, we talked about escape beats regarding the ventricles. We also talked about premature atrial contraction, which means it comes from an ectopic source, either from the AV node or from the atrial source, ممتاز. And we talked about how it can be premature and how it can look like retrograde P wave, or a P wave that comes as soon as possible, joined with the T wave, or in some cases, in some cases, you might just see a QRS complex without any P wave, where there's nothing depolarizing the atrium. It goes immediately towards the ventricle, accordingly. Regardless, they occur early, ممتاز, with a narrow QRS complex. Now, let's now talk about, I talked about these concepts now before I talk about the arrhythmias, because premature atrial contraction can predispose to these arrhythmias. And why is there a premature atrial contraction? Hypoxia, caffeine, whatever. And we talked about PVC and escape beats because they can predispose to ventricular tachyarrhythmia and why they might occur, ممتاز? So you might find these benign findings. You might notice them, ممتاز? Alright, now let's finally end this video by talking about non-sinus arrhythmia, which is the supraventricular tachyarrhythmias, the one that does have a P wave, and sometimes it may not have a P wave, sometimes it might have a retrograde P wave, but regardless, they will always have a narrow QRS complex that is the supraventricular tachyarrhythmias, where it can occur either due to a reentrant rhythm or an ectopic rhythm. And we'll talk about each one by one. So we will talk about 5 narrow complex tachycardia, 5 supraventricular tachyarrhythmias, which is the AV nodal reentrant tachycardia. We'll talk about PAT, paroxysmal atrial tachycardia. We'll talk about MAT, multifocal atrial tachycardia, atrial flutter, and finally atrial fibrillation. Now remember what we mentioned before, how step number 4, we ask ourselves 5 questions about the sinus rhythm. Is it normal? Is it sinus or asinus, or sinus or non-sinus? We will now apply this in knowing when to say this is AV NRT, when this is PAT, when this is MAT, when this is atrial flutter, and when is this atrial fibrillation. Now, regarding atrioventricular nodal reentrant tachycardia. Regarding this arrhythmia, what is the specific finding? Well, I want you to know that AV NRT is an arrhythmia that can occur in people with a normal heart. It can occur in people that are perfectly fine, but it can especially occur in people that drink caffeine, drugs, whatever, that stimulate the heart and predispose to a PAC. And a PAC can predispose to an AV NRT. How? Well, let's see. Let's see, we have a premature atrial contraction, all right? Here we have, for example, here we have a drawing. Here we have this side is the ventricle, and this side above is the atrium, ممتاز? And in between them can be the right and the left bundle branch, for example, ممتاز? Alright, so let's say we have an action potential going towards the left side and towards the right side from the atrium all the way towards the ventricle, right? Now let's say there's a premature atrial contraction. Let's say it occurred so fast and it reached towards one of the bundle branches, like let's say the right bundle branch or the left bundle branch, ممتاز? Let's say it reached the left bundle branch way too fast, and the left bundle branch, by the way, is still being repolarized. It's in its refractory period. It's telling it, whoa, 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 I am not done being repolarized. So go towards the other side. So let's say here, for example, we have a very premature atrial contraction. It reached this side towards the left bundle branch and tell it, no, I'm in a refractory period. I can't accept this action potential. Go the other way. ممتاز? Or we have an ischemia in this region. There's ischemia in this region, so you will go towards the other way. Regardless, what will happen next is very simply. What will happen next is that now all of these action potential, they will go towards the other way. Mumtaz? They will go towards the other way, and they will not come towards this way. Now, let's say this left bundle branch, let's say now it's no longer ischemic, or let's say it's no longer refractory. It's not refractory, it will now accept action potential. So if it accepts action potential, now guess what's going to happen? Now that this block is gone, now this action potential, look what's going to happen. This is what's going to happen. Now you have an action potential that will go towards this side. It will go towards the upward side. And now what's going to happen is that this action potential will go upwards. It will go upwards towards the atrium. And it will go downwards towards the ventricle. And if you notice, we form a loop. We form a loop circuit here, a reentrant loop circuit, where it goes all over the place. It forms this loop, and this loop is sending action potential all over the place. It's sending it towards the atrium backwards, and it's sending the action potential towards the ventricle forward, which is normal. But it's sending it all over the place, and it's forming this constant 24/7 reentrant loop. Mumtaz? And we can see this loop, especially in where can we see this? Especially in the AV node. So, to summarize, AV NRT from the name, AV atrioventricular nodal reentrant tachycardia, it occurs due to a reentrant rhythm. When you have a premature atrial contraction or a premature beat, when it comes to like the right bundle branch or whatever, it tells it, no, I'm in a refractory period, I can't accept it, go the other way. Then following the refractory period, once it's accepting it, now this action potential, instead of going left and right, is now going to go this action potential towards a loop, towards it. And now it's going to go towards the atrium the opposite way. So like the AV node, it's going to go the opposite way towards the atrium, and it's going to come towards the ventricle the same as always. So this will give us AVNRT. Mumtaz? AVNRT. So in AVNRT, we will have a reentrant loop circuit within the AV node, sending action potential towards the right atrium backwards, and sending action potential, as always, normally, towards the ventricles. Mumtaz? Mumtaz. Now, what would it look like on an EKG reading? Well, number one, we ask ourselves, is there a P wave? Yes, there's a P wave. However, if you notice, you can see that the P wave here is retrograde. And leg 2, like let's say leg 2, it's retrograde. Why is it retrograde? Because the wave of depolarization is going the opposite way. So away from the leg 2. So it will give us a retrograde P wave. And actually, in some cases, you might not even see a P wave in AVNRT. Some cases, the AV node will just continue depolarizing immediately towards the ventricles and not going towards the ventricles, not going towards the atrium. So you might not even see a P wave at some point. So in AVNRT, when we ask ourselves, is there a P wave or not? Well, we'll say 50-50. 50-50 meaning sometimes we might see a retrograde P wave, and sometimes we will not see a P wave. We will just see the QRS, which is narrow. It is normal. Mumtaz? What about the relationship? The relationship is non-existent. We'll say X. That means that the relationship between the P wave and the QRS, it is affected. There's no relationship because the action potential is not coming from the SA node to come to the AV node and eventually come downwards to give you PQRS. No, some cases, in most cases of FANRT, you'll not even see a P wave, or you might see a retrograde P wave. So the relationship here, you will not even see it, Mumtaz, or a normal relationship between the P wave and the QRS. And then the final question we ask ourselves, what about the rhythm? Is the rhythm regular or irregular in AVNRT? The rhythm is normal. Mumtaz, it is normal, meaning regular. Mumtaz, it is regular rhythm for AVNRT. And what about the heart rate? Well, in AVNRT, it is tachycardia. But when they refer to tachycardia, they don't refer to the ventricular heart rate. They refer to the atrial heart rate. So if you see a P wave, you might measure the PP interval, and you'll see that the heart rate is approximately 150 to 250 beats per minute. Mumtaz? So you might see 150 to 200 beats per minute. Mumtaz? All of these these, if I ask myself these questions, and these are my answers, this is AV and RT, in which we will not see a P wave, or if you do see a P wave, it's retrograde, or you'll see, besides the fact, you might see a QRS, which is narrow. You will see a relationship between the P wave and the QRS is non-existent, and you'll see that the rhythm is regular, such as in this scenario right here. You can see in this one, there's no P wave. There's just a narrow QRS complex followed by a T wave. Then a narrow QRS complex followed by a T wave. So the P wave will be hidden. It will be hidden here. It will not be seen here. Or if you do see it, you might see it as retrograde. Mumtaz? Mumtaz. This is AV and RT. The next one. The next one is paroxysmal atrial tachycardia. Now, PAT. PAT, I have good news for you. PAT has the same findings as AV and RT. The same EKG findings, Mumtaz. The same. No P wave, literally what we mentioned before. The PAT and the AV and RT look almost exactly similar. Everything I mentioned about AV and RT applies to PAT. The only way to differentiate between PAT and AV and RT is that when you do a carotid massage, this one has no effect. Now what does carotid massage means? It means very simply, if you have a girl, let's say a girl, she's having a party, let's say in Los Angeles. She's drinking alcohol, she's smoking, she's taking drugs, and let's say she's drinking caffeine, and this is all causing stimulation for the heart. Then suddenly during the party, she collapses on the floor. Now, let's say I did a carotid massage. I massaged the carotid artery for around 10 seconds. And then after I did this massage, suddenly the girl, she wakes up. She suddenly is able to regain consciousness. How is this possible? Well, more than likely this girl had a case of AV and RT. That means carotid massage, when we massage the carotid artery, it actually terminated this re-entering loop circuit. How? Very simply. When you massage the carotid artery, you're basically stimulating the baroreceptors, which are responsible for blood pressure regulation, right? Found in the carotid artery. The baroreceptors, when you stimulate them, they will give a signal to the brain. Tell the brain to go ahead and tell the vagus nerve to calm down the heart. And if you remember, the vagus nerve as a parasympathetic, one of its function is to have a parasympathetic input for the SA node, to tell it to calm down, to decrease its speed, and also for the AV node, right? So that's the idea. When you have a vagus nerve that is basically slowing down the SA node, and thus it can also slow down the AV node, this means that you can slow down this re-entering loop. You can slow it down, and at some point you can terminate its effect. Now, since there's little action potential, or action potential is coming slowly, now this action potential can go the normal pathway. It can go towards the left, and it can slowly come towards the right. So, carotid massage, by manipulating the parasympathetic stimulation of the SA node and AV node, can terminate the re-entering loop that is found in the AV node, Mumtaz, and thus terminate this tachycardia. Very effective. First line massage, Mumtaz. In AV and RT, it's very effective. In PAT, it will have little effect. Because in PAT, here, the same idea, the same finding, but here, another key difference is that since the carotid massage has no effect on it, that means that the ectopic source that is producing this arrhythmia is not coming from the AV node, just like AV and RT. It's not coming from the AV node. It's coming from a atrial ectopic foci, such as this one. And this one is the hadha. This one is functioning on its own. It has nothing to do with the SA node. Mumtaz. It will produce its own action potential and will send it towards the AV node. So when we try to do carotid massage, when we're trying to slow down the SA node and therefore the AV node, it will have no effect because it will not slow down this ectopic foci that is found within the atrium. This ectopic foci that predisposes or is the reason for the sudden appearance of a PAT. So carotid massage will have no effect on PAT, but it will have an effect on AV and RT. So that's one way to differentiate between them. Another difference, in PAT, unlike in AV and RT, in PAT, you might see a cool down, warm up period. So if you notice right here, there's no P wave. Or if you do see a P wave, it's retrograde. So there's no P wave, there's a narrow QRS complex followed by a T wave. And then following this sinus beat, you'll see a cool down period. Well, it will wait. It will wait some time, and then it will go to the next one. It finishes this one, it will go to the next one. So there's a cool down period. At the same time, you might see a warm-up period, where when there's this QRS complex, when it is beginning to form, it's warming up. It's taking time for it to go up, going up, 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 up. So there's a delay, there's a warm-up period, there's prolonged it here, and a cool-down period, there's also prolonged it here. You will not see this in AV and RT. In AV and RT, it's basically as soon as possible. Look at the difference. Look at the difference between this cool-down period, as soon as this one finishes, look at this cool-down period and compare it to this one. So you can just see the cool-down period. Is it longer and PAT, which it is, as compared to AV and RT. And you can also see the difference in the warm-up period, where you see the build-up of the QRS. Is it prolonged warm-up period or is it shortened? So that's the only way you can differentiate between PAT and AV and RT. Other than that, they're both the same. The only difference, the carotid massage, the period, and also the source. The PAT comes from an ectopic atrial source. AV and RT from the name, it comes from the AV node. Mumtaz? Mumtaz. Let's go to the next one. Let's go to MAT. Now, multifocal atrial tachycardia, it will give us this appearance. Let's ask ourselves, is there a P wave? Yes, there is a P wave. However, it is abnormal. Notice how this P wave and this P wave and this P wave, notice how each P wave, notice how each of them, hold on, notice how each P wave looks different from the other. Each of them have a different morphology. Each of them have a different shape. So if you have three or more different P wave morphology or shape, this is a good sign you have multifocal atrial tachycardia. What about the QRS? Narrow, normal, it's normal. What about the heart rate? In multifocal atrial tachycardia, it can be between 110 to 200. Mumtaz, beats per minute, the atrial heart rate. Mumtaz. Same goes for the PAT, if you're wondering. The heart rate's the same as AV and RT, but in multifocal you can see between 110 to 200 beats per minute. What about the relationship? The relationship between the two, it's actually also affected as well. You might see it, but you will see that the P wave, its morphology is affected. But we will say for this sake, we'll say it's normal. We'll say it's normal. You might see it. In some cases, you might not even see it, but we'll say it's normal for now. If you want to say a classical appearance of a MAT. Or, let me just say, let me be more accurate, let's clear off the confusion. We'll say 50-50, or we'll say relationship is abnormal. I want to just say that you might see a P wave followed by QRS. But again, with multifocal atrial tachycardia, with a lot of these supraventricular tachyarrhythmias, a lot of them may not even show a P wave. Some of them may not even show a P wave. So I just want to say the relationship is abnormal. Either you will see a P wave, and in the case of MAT, the shape is different for each one, or you will not see a P wave, but there's a QRS complex and a T wave. Mumtaz? So everything might be normal otherwise. So we will say 50-50, X. Mumtaz? This is according to your case. Now what about the rhythm? The rhythm here in multifocal is actually abnormal. It is irregular. It's irregular. What does it mean, irregular? That means if you compare the distance here is okay about this distance in the RR interval. Now compare this distance. This one is shorter than the next one. So we have an irregular rhythm. So in multifocal atrial tachycardia, one of the ways to easily distinguish it is you have an irregular rhythm. You can see a P wave, or you might not see it. If you don't see any P wave, or you do see a P wave, but you see at least 3 consecutive ones, each one with a different shape or morphology, and you see another QRS and tachycardia, then in that case you can diagnose this as a case of multifocal atrial tachycardia. Mumtaz? This is MAT. And why does MAT occur? MAT occurs because of an atrial ectopic source. You have an ectopic foci in the atrium. And this occurs specifically in people with chronic lung disease. So in people with hypoxia. So if a person has COPD or asthma, he may present with multifocal atrial tachycardia. You want to know how to treat it? Treat the cause. You treat chronic lung disease, you treat the hypoxia, you treat the arrhythmia. Mumtaz? Mumtaz. Type. This is the case of multifocal atrial tachycardia, in which from the name, you might have an ectopic foci in the atrium occurring here due to a chronic lung disease, hypoxia. Mumtaz? Mumtaz. So now let's go to atrial flutter. Atrial flutter, you will see that there's a P wave, but the P wave is AF. That means you will see the presence of flutter waves. where they're undulating across the baseline. And you might see 3 of them, which will give you the characteristic appearance of sawtooth appearance. So, when we say in a case of atrial flutter, when we ask about the P wave may show a flutter wave. And why does atrial flutter occur? Because, again, we'll have an ectopic atrial foci near the tricuspid valve or near the mitral valve, where it's sending its own source. And it's sending a lot of sources, which will give us the appearance of a P wave. There is fluttering, going up and down, giving us a sawtooth appearance. Mumtaz? Giving us a sawtooth appearance. However, the QRS is normal, it's narrow. What about the relationship? Well, we can see in the relationship there's multiple P waves and the QRS. So we will say it's abnormal. We will say a lot of P waves, where some P waves are not followed by QRS. Basically, when we're seeing these flutter waves, this basically means the atrium are being depolarized and they're contracting very, very fastly. And not all of this action potential is reaching down the ventricles. Why? Because remember, we have the AV node, which has its own conduction delay. It's telling it calm down. And also the remaining part, they're refractory. They're telling it calm down. We're still repolarizing. So we will have multiple atrial flutter waves, which represents the atrium. They're being depolarized so many times. But not each of these atrial flutter waves will come down to the AV node. Not every single one of them will come down to the AV node. So we'll have a bunch of flutter waves, and then we will have a QRS complex that's narrow. Mumtaz? So the relationship here between the P wave and the QRS is abnormal. And then finally, the heart rate and the rhythm. Regarding the heart rate, is between 250 to 350 beats per minute. Let's say 250 to 300 beats per minute, approximately, let's say. Mumtaz? This is very, very high, especially when you're assessing the atrial heart rate. 250 beats per minute to 300. And what about the rhythm? The rhythm in atrial flutter is normal. It is regular. Mumtaz? So in atrial flutter, you might have a regular rhythm. Mumtaz? You might have the presence of atrial flutter waves followed by a narrow QRS complex. You might have a heart rate of 250 to 350 beats per minute, and the relationship between the P wave and the QRS is affected. Mumtaz? Mumtaz. Now the final arrhythmia that we will check into, and it's one of the most dangerous arrhythmias, is atrial fibrillation. Now, in the case of atrial fibrillation, it's very simple. The P wave is abnormal. Actually, in P wave, we have too many. In the P wave, we will see a P wave, but there's so many, we're not able to distinguish one from the other. That's an atrial fibrillation. And the reason atrial fibrillation occurs, the difference between this one and this one, is that you'll have multiple atrial foci, here and here and here. They're sending so many depolarization waves towards the right and the left atrium. So you will have so many P waves, so many. You're not able to keep count. So this is one thing to keep in mind. The P wave, they're indistinguishable. Mumtaz? We're not able to distinguish it in atrial fibrillation. The next is the QRS. The QRS is normal. And remember, the QRS is basically the AV node. It's telling it, I have a conduction delay. I will not accept all of these depolarization. I will not accept all this action potential. I will delay. I will choose one and then move on. So the QRS complex is narrow and it occurs at their own rate. So the QRS is normal. Mumtaz? It's normal. The pen just finished. But regardless, the QRS is normal. The next one is the relationship. The relationship is obviously abnormal. We have so many P waves, but not every single one of them is followed by a QRS complex. So this is abnormal. What about the rhythm? The rhythm is the most important bit. The rhythm will always be by an X, abnormal, meaning irregular. The rhythm always is irregular. You check the pulse of the patient here or here, irregular rhythm due to many causes in atrial fibrillation, cytotoxicosis, pregnancy, whatever. When you have an irregular pulse, you should always think of atrial fibrillation. Think of atrial fibrillation with an irregular pulse. That's the first thing. That's the most dangerous. And then you can think of MATs, for example. So, in atrial fibrillation, you'll have too many P waves, abnormal. You have a narrow QRS complex. The relationship is completely ruined. The rhythm is for sure irregular. Look at the distance between these two. And finally, the heart rate for the atrial, like if you were to measure the atrial heart rate, is very, very high. It's between 300 to 500. You know, you might have it very, very high, from 300 up to 500 beats per minute. So it's very, very ridiculously high. Okay? This is how to diagnose atrial fibrillation, by asking yourself the questions, and really asking yourself the questions for each arrhythmia. What is the P wave, the heart rate, the rhythm, the relationship, and the QRS. Mumtaz. If you notice, now that we finished with atrial fibrillation, if you notice, all of these will have a P wave. But this P wave can be retrograde, it might have a different shape, or it might be hidden. But what is guaranteed is the QRS will always be narrow. That means the ventricles, they're fine. They will get their source from above. They will not get it from the ventricle pacemaker cell. So it will go their normal way. So there will always be a narrow QRS complex, but the P wave will be affected. And we will still have tachycardia from the atrial side. And if you notice, all of these supraventricular tachyarrhythmias, all of these narrow complex tachycardias, they occur due to an ectopic rhythm or due to a reentrant rhythm. Mumtaz? Due to a reentrant rhythm. So, now that we finished the non-sinus arrhythmia from the perspective of supraventricular tachyarrhythmia or narrow complex tachyarrhythmia, the final thing to end this video with, and to really complete our topic of arrhythmia, is by discussing the management of each of these arrhythmias in the context of cardiac arrest, or in the context of BLS. Mumtaz? So, in a nutshell, we will talk about that in the next videos. You know, once we finish the arrhythmia, we'll talk about the management for each one, and we will see eventually later on. So we will finish that video to complete it in the upcoming videos. But for now, we finished talking about each arrhythmia. We talked about step number 4. Remember these 5 questions. How we assess sinus arrhythmia and non-sinus arrhythmia. We talk about this is the normal, this is the sinus arrhythmia. We talk about these concepts PAC, PVC, escape beats. And we talked about the non-sinus arrhythmias here. Mumtaz? Mumtaz. That's it for the video. And we'll talk about now, the next video, ventricular tachyarrhythmia. Or, another word, wide complex tachycardia.